Let's jump right in. Welcome to this explainer. I'm your reimbursement and quality compliance specialist, and today we're decoding the exact alphanumeric language you need for diabetes quality tracking and prevention programs. Because look, getting these CPT, Category 2, 3, and MDPP codes wrong, it doesn't just skew your patient data, it literally triggers audits and stalls your reimbursement. So we're going to get it right.
Here's our quick roadmap for today. We've got Category 2 quality measures, Category 3 prevention codes, MDPP core and maintenance, diabetic management S codes, and finally, our sign-off.
All right, Part 1, Category 2 quality measures.
Okay, so accurate medical coding really requires anchoring the exact HbA1c percentage to the correct F code. You aren't just saying a test happened, right? You're actively documenting glycemic control. It's kind of like telling a clinical story with numbers. If your patient's HbA1c is tightly controlled at less than 7.0%, you use 3444F. As that percentage climbs up, your codes shift right along with it. It goes to 3051F for 7.0 to 7.9%, 3052F for 8.0 to 9.0%, and for anything over 9.0%, you've got to capture it with 3046F. Oh, and if you're just ordering or reviewing the screening, map that straight to 3754F. Simple as that.
Now, check out these corresponding M codes for glycemic status. They function a lot like those F codes, but these tie specifically into quality reporting assessments. We're seeing that exact same stepping pattern here, M1371 for under 7.0, all the way up to M1211 for anything greater than 9.0. But I want you to pay really close attention to M1212. You use this one if the assessment is missing or, just wasn't performed during the measurement period. In the compliance world, accurately reporting a gap in care is honestly just as critical as reporting a success if you want to maintain a squeaky clean audit trail.
Moving right along to Part 2, Category 3 prevention codes.
So there is a massive divide in how we actually bill for the delivery methods of intensive prevention programs. CPT 0403T requires a standardized curriculum in an in-person group setting, and it demands a minimum of 60 minutes per day. Now contrast that totally with CPT 0488T. That one covers an online or electronic structured intensive program for an individual, and it's billed per 30 days. The clinical goal? It's exactly the same, but the coding completely bifurcates based on whether you're doing daily face-to-face sessions or monthly digital engagement. It's a real game changer to know the difference.
Okay, Section 3, MDP Core and Maintenance.
For your Medicare beneficiaries in the MDPP, billing is basically a chronological footprint of their retention during those crucial first 6 months. You kick off the cycle with G9733 for their very first core session, and from there, it is completely a volume game. 4 total core sessions within those first 6 months, that gets reported as G9874. And when they successfully hit 9 total sessions in that same time frame, you upgrade it right to G9875.
Once we enter the maintenance phases, clinical outcomes really dictate your coding. In months 7 through 12, codes like G9876 through G9879 are applied when they attend maintenance sessions, but, and this is a big but, only if the beneficiary maintains a baseline weight loss of at least 5%. Actually, hitting specific milestones triggers distinct codes too, like G9880 for a 5% weight loss, or G9881 for an impressive 9% weight loss. Ongoing maintenance in months 13 through 24 uses that G9882 through G9885 block, which again is entirely contingent on keeping that weight off. Finally, for the administrative side, use G9890 as a one-time bridge payment if a beneficiary transfers suppliers, and G9891 as a mandatory, non-payable reporting code to just track those performance goals.
Down to Part 4 already, Diabetic Management S codes.
When we're billing for standard diabetic management, the entire code basically pivots on the provider's credentials. Literally, who is in the room absolutely matters. A follow-up visit to a non-MD provider, that's S9140. But if an MD performs that exact same visit, the code shifts over to S9141. Group sessions, those fall under S9455. If a nurse is taking the lead, you'll bill S9460, and if a dietitian steps in for nutritional management, you apply S9465. Swapping these provider-specific S codes around is honestly a fast track to denied claims, so always verify credentials before you code.
And finally, Part 5, the Decode Healthcare Sign-Off.
Look, mastering these complex code sets is really the only way to protect your revenue cycle and ensure that your preventative programs actually get the funding they deserve. So I want you to take a hard look at your recent claims. Are you actually capturing every single milestone, or are you just leaving compliance and revenue sitting on the table? Think about that for your next audit. If this explainer clarified your coding processes, like, share, and subscribe to Decode Healthcare with Harshal.